goal of this presentation is to discuss the dorsal wrist compartment anatomy of the multiple tendons crossing the wrist joint in the 6 compartments present underneath the extensor retinaculum. For scanning the 6 wrist compartments accurately, a major bony landmark is used. This bony landmark is called the dorsal tubercle, or more commonly known as Lister's tubercle. The Lister's tubercle can be found on the radial side, on the same level as the round shape of the styloid process of the ulna. The Lister's tubercle forms the boundary between the 2nd and 3rd compartment. The Lister's tubercle and the styloid process of the ulna indicate the imaginary line where the sonographer should start scanning the wrist compartments. All of these compartments and the rest of the region are enveloped by the dorsal fascia of the hand. Parts of the dorsal fascia are thickened at the wrist level, and its fibers follow a course from ulnar to radial. This is the extensor retinaculum, which stabilizes and protects all compartments. Let's start with the first compartment, which contains the APL, the abductor pollici longus, and the EPB, the extensor pollici brevis. Palpate the APL and the EPB in compartment 1. If you are unsure of how to locate these, please palpate the area of the Lister's tubercle and make a pistil with your hand. Once you've made the pistil, palpating the APL and the EPB on the side of the radius should be easier, as you'll feel the tendon dynamics when doing thumb extension or thumb abduction. The APL originates from the ulna, radius, and interosseous membrane. It inserts distally and superficially on the radial side of the base of the metacarpal bone. It also has a variable proximal deep insertion part on the trapezium, joint capsule, or belly of the APB. The APL abducts and extends the thumb. Please keep in mind that in about 80% of all people, accessory APL tendons are present. So it's most likely possible that you won't find one APL tendon, but multiple. The EPB originates from the proximal radius and interosseous membrane. It inserts on the proximal phalanx of the thumb. The EPB extends and abducts the thumb at the metacarpophalangeal joint. An anatomical variant that you might encounter is the absence of an EPB. In this case, there will be a fusion with the tendon of the extensor pollici longus, which can be observed in the 3rd compartment. The first compartment is innervated by the superficial branch of the radial nerve and vascularized by the radial artery. Compartment 2 contains 2 structures, the extensor carpi radialis brevis and longus. To locate this compartment, palpate Lister's tubercle and slide a bit to the radial side of the tubercle. If the patient does a slow dorsal flexion movement combined with radial abduction, the tendons of the extensor carpi radialis longus and brevis can be found. Compartment 3 contains the extensor pollici longus, or EPL. Compartment 3 can be found immediately on the ulnar side of Lister's tubercle. Lister's tubercle is an important landmark for the EPL, as this muscle has a proximal to distal course until it reaches Lister's tubercle. At this level, it suddenly angles around Lister's tubercle and courses diagonally in a radial direction towards the thumb. The EPL originates from the interosseous membrane and the middle third of the posterior ulnar surface. Its insertion can be found on the base of the distal phalanx on the thumb. The EPL extends the thumb in the metacarpophalangeal and interphalangeal joint. The EPL is easy to identify on a transverse ultrasound view, as it is a single tendon on the ulnar side of the Lister's tubercle of the radius, which is the most perfect bony landmark. The EPL of compartment 3 and the EPB and APL of compartment 1 together create the anatomical snuff box. This anatomical snuff box was used in the past to sniff tobacco, hence its name. The anatomical snuff box becomes visible when adopting the same hand position as shown in this image. Compartment 4, which contains the ED or the extensor digitorum and the extensor indici, can be found in the middle of the wrist, again on the imaginary line between listus tubercle and the styloid process. When one does extension of the digits, the ED tendon dynamics can be palpated in compartment 4. Compartment 5 contains the EDQ, the extensor digitorum quinti. This EDQ is also called the EDM, the extensor digiti minimi. So the EDQ and the EDM are actually the one and same structure. Compartment 5 can be found exactly superficial of the distal radio-ulnar joint. When palpating the joint and extending the fifth digit, the tendon dynamics of the EDQ can be palpated. The ED originates on the lateral epicondyle of the humerus at the common extensor tendon. The ED inserts on the extensor expansion of the middle and distal phalanges of the second, third, fourth, and fifth fingers. The ED extends the phalanges, mainly the proximal phalanges, then the wrist, and finally the elbow. The ED tends to separate the fingers as it extends them. Compartment 6 contains a single tendon, the ECU or extensor carpi ulnaris. It can be located by feeling the dimple that you can palpate if you glide off the ulnar styloid process towards the ulnar side. This dimple contains the ECU. The ECU can be felt moving when the wrist is dorsally flexed with ulnar abduction. The ECU originates from the lateral epicondyle of the humerus and common extensor tendon. The muscle inserts at the base of the fifth metacarpal. It extends the wrist with a slight ulnar abduction of the hand. This image shows the ECU tendon coursing into compartment 6, the tendon sheet of compartment 6, and the overlying extensor retinaculum that stabilizes all compartments in the dorsum of the wrist. The goal of this presentation is to discuss the dorsal wrist compartment anatomy of the multiple tendons crossing the wrist joint in the 6 compartments present underneath the extensor retinaculum in musculoskeletal ultrasound. In this image, you can see where to place the transducer when examining the first compartment with a transverse or short axis view. Start on the side of the radius at the level of listus tubercle and slowly sweep the transducer to distal. On the ultrasound scan, the anatomy found is the APL, the EPB, and the superficial branch of the radial nerve. Let's highlight these structures for easier interpretation. Do you see both tendons underneath the hypoechoic tendon sheet? As mentioned before, the APL can show several tendons due to its variability. Please notice the hypoechoic tendon sheet tissue between the 2 tendons, which divides this first compartment into 2 chambers. Please note the yellow arrow on the top left, which indicates the superficial branch of the radial nerve. This nerve lies next to the APL. The superficial branch of the radial nerve crosses above the tendons of the APL and EPL as the transducer is moved to distal. When you move further to distal, you can find the nerve on top of the APL, which incidentally has trifurcated in this specimen. Even more to distal, the nerve has shifted to the side of the EPB. This slide shows the ultrasound as well as schematic appearance of multiple normal APL tendons. The transducer is placed transversely or with a short axis view, as shown in this image. Start at the radial side of listus tubercle. Once the extensor carpi radialis brevis and longus are visualized, the transducer is moved proximally along the tendons. The two hyperechoic tendons in compartment 2, the extensor carpi radialis brevis and longus, can be seen with the hypoechoic tendon sheet. Please also observe the division in the chambers that divides the brevis from the longus. The extensor carpi radialis brevis always lies closest to Lister's tubercle. Following the tendons of compartment 2 increasingly to proximal, as shown in this image from left to right, the compartment 1 muscles will encroach superficially to the extensor carpi radialis brevis and longus and will become bigger in size. The anatomy, as shown on the right side of this image, is a site of possible pathology. The transducer should be placed transversely, or with a short axis view, on the ulnar side of Lister's tubercle. From there, the transducer should be swept distally to observe the EPL course. The image shows at A, the starting position, the EPL tendon situated on the ulnar side of the Lister's tubercle. B and C show the EPL tendon encroaching superficially from the tendons of the second compartment, the extensor carpi radialis brevis and longus, to the extensor digitorum communis tendon, which belongs to the fourth compartment. The EPL can be found on the ulnar side, on this image on the right side, of the Lister's tubercle, here clearly visible in the middle of the image. The EPL is a single tendon in compartment 3. This image shows the EPL tendon in blue, encroaching superficially from the tendons of the second compartment, the extensor carpi radialis longus and brevis tendons. As illustrated, it moves away from the tendon of the extensor digitorum communis, which belongs to the fourth compartment. To assess compartments 4 and 5, the transducer is placed transversely or with a short axis view on the dorsum of the wrist at the level of Lister's tubercle and the styloid process. From there, the transducer is swept to proximal and distal to assess the full ED and EDQ. Compartment 4 can be seen as a group of clustered tendons within the tendon sheet right above the flat part of the radius. Note the hyperechoic tendons and the hypoechoic tendon sheet, which surrounds the ED tendons. Compartment 5 can be seen right above the distal radioulnar joint. Wait, let us highlight the anatomy so that you can see it a bit better. When extending the second, third, and fourth digit, the ED tendons in compartment 4 can be seen rotating. When extending the fifth digit of the EDQ tendon in compartment 5, statically often hard to locate, can be seen moving. Place the transducer transversely, or with a short axis view, at the ulnar side of the styloid process. Search for the little dimple that contains the ECU. The hyperechoic ECU tendon can be seen within a hypoechoic tendon sheet. Occasionally, the stability of the ECU can be impaired. Scanning the ECU while the patient performs an active pronation or supination can be useful to assess the stability of the tendon. This presentation highlighted the anatomy, scanning techniques, and ultrasound images of the 6 dorsal wrist compartments and the content within each. Compartment 1, the extensor pollici brevis and abductor pollici longus. Compartment 2, the extensor carpi radialis brevis and longus. Compartment 3, the extensor pollici longus. Compartment 4, the extensor indici proprius and the extensor digitorum communis. Compartment 5, the extensor digiti quinti. And finally, compartment 6, the extensor carpi. The goal of this presentation is to discuss the dorsal wrist anatomy of the carpal bones, the scapholunate ligament, and the triangular fiber cartilage complex. This is a schematic drawing of carpal bones and wrist joint spaces. Distal to the radius and ulna, the proximal row of carpal bones include the scaphoid, the lunate, the triquetrium, and pisiform, whereas the distal row is formed by the trapezium, the trapezoid, the capitate, and hamate. The distal radio-ulnar joint is separated from the radiocarpal joint by the triangular fiber cartilage complex. The scapholunate and lunotriquetral ligaments separate the radiocarpal from the midcarpal joint. The carpometacarpal joint spaces lie ahead of the distal carpal row. Many people have difficulties remembering all the names in the right order. One could remember it by thinking of the following phrase: sex lovers try positions that they cannot handle. Each first letter of the word stands for a certain bone that starts with the same letter. The order of the words reflect the position of the bone. The ligament between the scaphoid and lunate bone, the scapholunate ligament, is one of the important stabilizers of the wrist. Abnormalities of this ligament may cause scapholunate instability, scapholunate dissociation, and rotatory subluxation of the scaphoid bone. The diagnosis of a scapholunate ligament abnormality has proven to be difficult. Ultrasound can help in the diagnosis of scapholunate ligament pathology. In ultrasound images, the dorsal aspect of a healthy scapholunate ligament appears as a hyperechoic and fibrillar structure. Hypoechogenicity, discontinuity, or absence of such a structure indicates disruption of the dorsal aspect of the scapholunate ligament. The triangular fiber cartilage complex, or TFCC, is a complicated structure located on the ulnar side of the wrist. The complex is composed of multiple distinct anatomical structures that together play a critical role in wrist biomechanics. The TFCC acts as the main stabilizing element of the ulnar side of the wrist and is responsible for transmitting approximately 20% of the forces that cross the wrist when there is neutral ulnar variance. Yet, this structure also allows a remarkable and complex range of motion. Injury to one or several of the structures of the complex may lead to ulnar-sided wrist instability, pain, and clicking, which further may lead to disability. Although others have variably defined the constituent anatomy of the TFCC, here we mention the most commonly included structures and important parts of this complex. These structures include the following 8 components: the triangular fiber cartilage disc, dorsal and volar distal radio-ulnar ligaments, meniscal homologue, ulnocarpal collateral ligament, ulnotriquetral and ulnolunate ligaments, both being volar structures, and the extensor carpi ulnaris tendon subsheath. In this cadaveric specimen, highlighted with black lines, you can see the TFCC. Please notice that it's hard to differentiate between individual structures, as for its major part it looks like one solid fiber cartilage mass. Imaging and assessment of the TFCC continues to be a challenge for radiologists because of the complexity of the constituent structures, their small size, and close relation to one another. In addition, the pattern of injury in TFCC trauma can be quite varied and may be difficult to detect and differentiate from normal anatomical structures. The goal of this presentation is to discuss the dorsal wrist anatomy of the carpal bones, the scapholunate ligament, and the triangular fibrocartilage complex in musculoskeletal ultrasound. To evaluate the radiocarpal and midcarpal joints, the sonographer has to longitudinally connect, in other words in a long axis view, the two bones that together create the specific joint. If the sonographer is interested in the joint between the radius and the lunate, or between the lunate and the capitate, the transducer has to be placed at the position shown in this image. The obtained ultrasound image will show, as seen in the image from right to left, the radius and lunate, and in between the radiocarpal joint. It also shows the lunate and the capitate, with in between the midcarpal joint. At the far left, the metacarpal bone and the capitate can be seen, with in between them the carpometacarpal joint. The soft tissue that can be seen lying superficial to the bone is the extensor digitorum tendon, visualized in green. The yellow stars indicate the ligament between the carpal bones, in other words, the dorsal intercarpal ligaments. The blue stars indicate the ligament between the radius and carpal bones, the dorsal radiocarpal ligament. Of course, a capsule can be found near a synovial joint. The yellow arrows indicate the dorsal synovial recess of the midcarpal joints, and the blue arrows show the dorsal synovial recess of the radiocarpal joint. To scan the scapholunate ligament, place the transducer transversely at the level of Lister's tubercle, and then sweep it to distal until the scaphoid and lunate bone can be seen. The hand of the patient is abducted to ulnar. The echostructure and integrity of the dorsal part of the scapholunate ligament is evaluated. In case of a ligament tear, a gapping of the scapholunate joints can be seen, clearly a sign of stability loss. The obtained ultrasound image shows the hyperechoic osteology of the lunate and scaphoid bone. And of course, the scapholunate ligament, here indicated with blue dots. You can see the hyperechoic parallel fibers which connect the scaphoid with the lunate bone. This picture shows the positioning of the wrist and transducer in order to scan the dorsal aspect of the triangular fibrocartilage disc and the meniscus homologue. Observe that the patient's hand is in pronation and slight radial deviation. The ultrasound scan obtained shows the dorsal aspect of the triangular fibrocartilage disc and the meniscus homologue, with the extensor carpi ulnaris tendon sheath used as an acoustic window and the wrist in pronation and slight radial deviation. Normal echogenic appearance of both structures can be seen. Note the fibrillar appearance of the extensor carpi ulnaris tendon. In this picture, you can see the position of the patient's wrist and transducer in order to scan the radial collateral ligament. The ultrasound scan shows the radial collateral ligament region, while the patient has his hand in pronation. Note the echogenic appearance of the presumed radial collateral ligament fiber.
Welcome to this presentation about the anatomy of the carpal tunnel. Let's have a look at the cause of the median nerve. After the union of the medial nerve and the lateral roots. Distal to the union of its brachial plexus roots, the median nerve runs in the medial bicipital groove above the brachial artery to the elbow and passes under the bicipital aponeurosis and between the two heads of the pronator teres to the forearm. After given of the ane, the anterior antebrachial interosseous nerve distal to the pronator teres, the median nerve runs between the flexor digitorum superficialis and profundus to the wrist and passes underneath the flexor retinaculum, the transverse carpal ligament in the carpal tunnel to the palm of the hand, where it divides into the terminal branches. The carpal tunnel is an inelastic structure. Axial view of the bones shows the main bony landmarks of the carpal tunnel. The proximal carpal tunnel is delimited by the pisiform at the ulnar side and the scaphoid at its radial side, whereas the distal carpal tunnel is bounded by the hook of the hamate and at its ulnar side and the tubercle of the trapezium at its radial side. These bones give insertion to the transverse carpal ligament. Gross dissection of the ventral wrist demonstrates the position of the median nerve relative to the bony landmarks shown in the image at the left side. In the image on the right side, the transverse carpal ligament is indicated with red dots. Note in the right image, on the bottom of the red arrow indicated the flexor radialis tendon, which is orientated straight on the scaphoid, and the flexor carpi ulnaris inserting on the pisiform, also indicated with a red arrow. The median nerve and the flexor digitorum superficialis course in between these tendons. The carpal bones form a convex arch on the dorsal side of the wrist and concave arch on the palmar side. This creates the carpal tunnel on the palmar side, which is bounded by the bony elevations on the radial and ulnar sides. On this slide you can see the cross sections through the proximal on the left side and the distal on the right side, parts of the carpal tunnel. So once again, the tubercles of the trapezium and the scaphoid form the palpebral eminence on the radial side, while the hook of the hamate and the pisiform bone form the eminence on the ulnar side. Note that the carpal tunnel is narrowed over the center of the distal row of the carpal bones, visualized in the right image. This has been described by Schmidt and Lance as the real carpal tunnel. The flexor retinaculum, the transverse carpal ligament, is stretched between the previously described bony landmarks and closes the carpal tunnel on the palmar side. Now you know the bony and ligamentous anatomy of the carpal tunnel. But which soft tissue structures can we find in the tunnel? The content of the whole carpal tunnel can be seen in this beautiful transverse wrist cut. The flexor digitorum profundus, 4 in total, and the flexor digitorum superficialis, also 4 in total. The flexor pollicis longus tendon, and radial and outside from the carpal tunnel, but regarded as part of the tunnel, we can see the tendon of the flexor carpi radialis, and superficial to these tendons, the median nerve. Let's dissect and open the palmar side of the hand and study the median nerve in detail. What do we see? The first structures that can be seen underneath the transverse carpal ligament is the median nerve. The median nerve is superficial to the flexor digitorum tendon and divides into a lateral and a medial branch. The lateral branch of the median nerve supplies the thenar muscles, the opponens pollicis, the abductor pollicis brevis, and the superficialis part of the flexor pollicis brevis. The lateral branch of the median nerve is also called the recurrent branch. The common palmar digital nerves of the medial portion of the median nerve divides into common palmar digital nerves. The first of these give a twig to the second lumbricalis and runs toward the cleft between the index and middle fingers, where it divides into 2 proper digital nerves for the adjoining sides of these digits. The second runs toward the cleft between the middle and the ring fingers and splits into 2 proper digital nerves for the adjoining sides of these digits. It communicates with the branch from the ulnar nerve and sometimes sends a twig to the third lumbricalis. Distal to the recurrent branch, the median nerve divides into 3 proper palmar digital nerves of the median nerve, also called the proper volar digital nerves. 2 of these supply the side of the thumb, while the third gives a twig to the first lumbricalis and is distributed to the radial side of the index finger. It also divides into 2 common palmar digital nerves. The first of these divides into 2 proper digital nerves for the adjoining sides of the index and middle fingers. The second common palmar digital nerve splits into two proper digital nerves for the adjoining sides of the third and fourth digits. Here you can see the innervation of the fingers by the median nerve. Many variations in branching pattern of anatomy of the median nerve have been described. These include high division, persistence of the median artery, anomalous subretinacular muscle and tendon attachments, and proximal cross-connections with the ulnar nerve, most of which are rare. More commonly seen are proximal incursions of the lumbricalis muscles. Variations in the branching and causes of the recurrent motor branch we can see in this picture. The most common pattern of the motor branch is extraligamentous and recurrent. Subligamentous branching of a recurrent median nerve, transligamentous cause of the recurrent branch of the median nerve. In carpal tunnel syndrome, signs and symptoms may include weakness and wasting of thenar muscles with sensory disturbance over the radial 3.5 digits, but not over the palm of the thenar eminence. The latter skin areas are supplied by the superficial branch of the median nerve that arises proximal to and passes into the palm superficial to the flexor retinaculum. This photograph shows an ape-hand deformity of the right hand of a patient with severe median neuropathy at the carpal tunnel level after a carpal tunnel release with a skin depression due to loss of bulk of the intrinsic muscles at the thenar eminence. We discussed the carpal tunnel in detail. There is still one tunnel in the wrist region to explain. The Guyon or ulnar tunnel. This tunnel is situated on the top of the proximal carpal tunnel and created by the palmar carpal ligament, functioning as the roof of the tunnel and attaching to the tip of the pisiform bone and the transverse carpal ligament. At the transverse carpal ligament, the roof of the carpal tunnel, which acts now as the floor of the ulnar tunnel. The ulnar tunnel is only present on the top of the proximal tunnel. At this image you can see that there is no tunnel present on the top of the distal carpal tunnel. The ulnar tunnel contains the ulnar artery and the ulnar nerve. The image on the left illustrates the cause of this neurovascular bundle. In the distal portion of the tunnel, the ulnar nerve divides into a superficial sensory branch and a deep motor branch. Close to the nerve, the ulnar artery bifurcates in the respective deep and superficial branches. On this slide, you can see an illustration of the three compartments of the ulnar tunnel. The three anatomical compartments are the proximal, middle, and distal ulnar tunnel. Each has its peculiar boundaries and relationships. The middle fibro-osseous compartment was the narrowest, but the third or distal compartment was the most dynamic. The ulnar tunnel is a dynamic space with dimensions and relationships that are influenced by wrist motion. To scan the proximal part of the carpal and ulnar tunnel, place the transducer transverse in short axis on the proximal row of the carpus formed by scaphoid, capitatum, triquetum and pisiform bone. The osteology of the proximal carpal row in the ultrasound image can be seen as hyperechoic lines with acoustic shadow underneath. The scaphoid, the capitate bone, the triquetrum and pisiform bone. The ultrasound image that is captured shows the transverse carpal ligament, which appears as a thin, slightly convex band of 1 to 1.5 mm thickness. Inside the carpal tunnel, the median nerve can be found as a hypoechoic oval structure immediately underneath the transverse carpal ligament. The flexor digitorum superficialis and profundus tendons and the tendon from the pollicis longus. On the radial side, the flexor carpi radialis tendon, And of course, on the ulnar side, on top of the transverse carpal ligament, we can see the ulnar tunnel containing the ulnar artery and ulnar nerve. To scan the proximal and distal carpal tunnel longitudinally in long axis, place the transducer in the length of the tunnel on top of the median nerve. The osteology that can be seen are the radius, the lunate and the capitate bone. These bones are connected to the radio-lunocapitate ligament. The myology that can be seen is the tendon of the flexor digitorum profundus, the flexor digitorum superficialis, and the neurology present is the median nerve, which can be seen slightly more hypoechoic as the tendons of the flexor digitorum. The most important key messages of this presentation for you to remember are: first, the distal parts of the carpal and ulnar tunnel are the parts which are most at risk. Secondly, the median nerve bifurcates in most people in the distal tunnel. And last, not a key message of this presentation but more a tip, please know your anatomy of both tunnels.